Well, thank you for coming. My name is Gene Lengerich. I'm a professor in public health sciences, and I also have the honor to direct the public health preparedness option in the Homeland Security Master's and Graduate Certificate programs. That's a mouthful, but I've been doing it for about 5 or 6 years and really enjoy it. And this is a real unique opportunity for us to get together and talk about hospital preparedness. If you are not familiar with it already, there are a group of students from the University of Split in Croatia here doing an assessment along with a few of our students to look at the hospital preparedness of Hershey then as well as their hospital back home. One of our panelists, Jim Holliman, has actually been a consultant to Croatia a couple of times, so he's got some personal experience there as well. Are the students from Croatia here? No, they're not. Okay. Well, we do need to get started. They hopefully will come in just a little bit later. But one of the things I wanted to do is to make sure that you all are familiar with what's kind of driving this group of people here right now, and that is particularly these graduate programs. So obviously public health preparedness, hospital preparedness is an important issue. Here's a word cloud that sort of describes some of the things that we are thinking about here. Actually, I saw an interview last night on the news of the director of the Texas Medical City, all of the hospitals there in Houston, and I guess one of the things that I took from that is that he certainly gave the impression that everything's under control from the hospital perspective. Of course, they got a lot of water, but it's not infiltrating into their hospital and changing their practices in any way. And if that's all true, that's fantastic. What a change from what happened in Katrina 12 years ago. Our program it offers the Master of Public's Master of Professional Studies in Homeland Security with a public health preparedness option. It's 33 credits. It's delivered totally online, offered through the World Campus. And I think we did send the notice out to some of our students around the country, and I think a few of them were going to try to participate via Zoom. So hopefully this is working. Thank you, Chula Paul. He has been helping us to get this together. He is associated with our program as well. He's the instructional designer, so that if you were in a course, you may encounter him occasionally as well. But it is a Master of Professional Studies in Homeland Security, the Public Health Preparedness option, 33 credits, taught totally online. We also have 2 graduate certificates, 12 and 15 credits. The first one has been around since the program began in 2006 in Public Health Preparedness. The second one is relatively new in Hospital and Health System Preparedness, and it is a subset of the overall courses. Our goal in that program then is to advance the knowledge and competencies of students so that they can lead domestic and global efforts in public health and hospital preparedness. And that certainly is what we have been doing over the past 12 years or so. And I guess one of the things that I want to weave into this also is the issue around global health security. And that is an incredibly important topic and one that is getting a lot of attention from CDC, the Department of State, WHO, and others as well. One of our faculty instructors, Dr. Gavin MacGregor-Skinner, who you can see right there on the screen, is closely associated with that whole initiative, and he's going to tell you a bit more about that. But we really see our whole hospital preparedness, public health preparedness fitting into global health security. And of course, it's a program, so we're all striving towards graduation. And this is the picture of those who commenced. Mostly these are students, but you do see a couple of faculty members, Gavin, Jim, Jen, myself, and Jim McKenzie also, who's no longer, he's retired, but this is about 2014. So we admit about, yeah, I must have missed that slide. But we admit about 50 students per year all across the U.S., and we also have some international students. As I said before, it's all totally delivered online, and it is again, offering a Master of Professional Studies. We have several of our physicians here at the Med Center that are either gone through it or are going through it. And I think we've gotten pretty good, they've benefited a lot from it. So I think that's the end of the slides that I have. There are, I guess one other thing that I didn't see a slide for, that we have about 8 different public health preparedness courses that we offer. Most are 3 credits. There's an independent study credit as well. So I have flyers about the program. I don't have enough to give everyone, but in a moment I'll walk up and make sure that at least some get distributed at the back so that you can pick those up on the way out if you're interested. But before we do get started with our panel, I do want to introduce a couple of other people. Dr. Ninen Gannon is in the back there. Caught her with her mouth full, sorry about that. So Dr. Gannon is one of our faculty members, and she primarily teaches the research capstone project. Dr. Bruce Rudy also teaches that. Chulapal Thanamissing, I mentioned before, but he's the instructional designer for the program then as well. And now just kind of Jan Osatek, she I thought was going to participate via Zoom, but I don't see her up there, but she's another one of our faculty members. She's with the U.S. Coast Guard and brings in sort of a border security perspective. And now let's go ahead and get started with our introductions here for the panel. First to my right is Dr. Jim Holliman. I think many of you know him. He's a professor in public health and emergency medicine and public health sciences, and has been teaching our PHP 530, which is our hospital preparedness program, development of an emergency response plan for the past few years, doing a great job with that. As many of you know, he is really world-renowned in the area of emergency medicine preparedness. So he brings a wealth of experience to this from an international perspective. Our next speaker is Dr. Gavin MacGregor-Skinner. He's in, I'm not sure where he is. He may be in Bethesda. Are you in Bethesda?
Yeah, yes, I am, Jim. Gene, I'm in Bethesda today.
That's unusual because he's usually traveling around the world. For the past 15 to 20 years, he's been intimately involved in a number of outbreak and disaster situations, from Ebola to SARS to some veterinary medicine ones in Europe as well, disasters, earthquakes, tsunamis. He's got a wealth of experience as well. And then our next speaker is Dr. Bruce Rudy. Bruce is, as I said before, he's the instructor. He was the instructor this past summer for our capstones experience. He was originally involved with the program way back when, and then came back to it. And he adds a really unique perspective to this because he's a physician assistant, but he's also the coroner of Lebanon County. So from a real practical perspective, then he views this here. So good enough? I think I'm going to stop there. And what we've asked each person to do is talk to 10 to 15 minutes, save a few minutes at the end for questions and answers.
Well, welcome everybody. My career has been centered around the development of the specialty of emergency medicine and emergency medicine training programs in other countries. And one of my long-term career interests is in encouraging and assisting students and residents in obtaining international clinical experience. So even if you're not interested in a career in global health, I strongly, strongly recommend to all the students and all the residents to undertake an international clinical experience, because I think it can really be a life-changing kind of event. And even though it may cost you some more money for the travel, go ahead and spend it, because again, there's not much difference in graduating from medical school with a $150,000 debt and a $152,000 debt. So go ahead and take advantage of the experience. So again, if there's anything I can do to help any of you all obtain international clinical experience, that's one of my central interests. One thing that you might be interested in that I just found out about yesterday is that AHC Media, which is the company that produces emergency medicine reports, is advertising that they are conducting a webinar on the new rules that hospitals have to abide by, which come into effect November 15th. And this webinar is about these new regulations that are coming from several different federal agencies that apply to all hospitals that we're going to have to come up with, making sure that we meet these new regulations related to hospital preparedness. Then one of my main roles in connection with this is as the lead faculty for the course PHP 530. Which, as Gene mentioned, is part of the Masters in Homeland Security program. But you can also take this course as just an isolated course. It's completely online. Its title is Critical Infrastructure Protection of Healthcare Delivery Systems. And this is offered in the spring semester, and again, it would be open to any of you all that might be interested. We have students from all over the country, and usually from several other countries. That includes doctors, nurses, police officers, retired military, active military, security personnel, and a variety of other people that are interested in this subject. In the course, what we do is review the infrastructures of transportation, energy, water, communications, and information technology, and approach those sort of sequentially in how each of those infrastructures applies to the hospital situation and how you have to take into account aspects of each of those infrastructures in designing hospital plans. So what we do is take the students are divided up into teams, and they develop a so-called vulnerability assessment that's tiered for each of these different infrastructures, and then from their vulnerability assessment, they develop a ERP or emergency response plan that's for a hypothetical hospital, and then proceed through the course to gradually expand the content of this emergency response plan so that it covers all aspects related to all the different infrastructures. Then we were asked also to provide some kind of personal background for our work. And so one of my experiences involved related to this was when I was working full-time for the U.S. military. One of my tasks was to develop disaster and mass casualty management plans for the Afghan National Army and the Afghan National Police Force. And as you might imagine, that was just a little bit difficult because what it involved was getting several different ministries to work together, which is difficult in the Afghan environment. So as an example, the Ministry of Education was in charge of medical school curriculum and the training of other healthcare professionals, but there was a separate Ministry of Public Health that was in charge of the hospitals and the hospital personnel and some of their training. And so there was a split between two different ministries for healthcare training. And then, of course, we had the Ministry of the Interior was the supervising ministry for the police force. And then we had the Ministry of Defense, which was the supervising ministry for the Army. And so one of the tricks in getting coordinated disaster planning for Afghanistan was getting these four ministries to work together smoothly. And you have the same situation if you get involved with higher level planning in the United States. The same situation applies here in that, for instance, in Dauphin County, as we're doing our hospital planning for disaster and mass casualty management, we need to closely involve the county emergency management agency, all of the local fire and emergency medical services units, as well as some of the other governmental administrative personnel. We have to get all these people to work together and get all these people to agree to the unified plan. And then, of course, the way for a plan to actually be effective is it has to be practiced. And so the other trick is to get all these different people together at the same time for drills related to operation of the plan. And I think Hershey Medical Center actually has a very well done, it's complex, but it's a very well done and complete plan for both mass casualty management and management of terrorist incidents. It's available, you can access the whole plan online, it's fairly easy to access. And I think I'll conclude and the slide set, wasn't sure if it got set up. The slide set I brought for this session is actually 72 slides. It's on hospital disaster planning. And so it's too many slides to present, but if you would like a copy of it, just let me know afterwards. I have it on memory stick and I can easily copy it for you if you want to see the whole presentation. And it has a lot of good, I think, reference information in it. And then I have another probably 50 lectures on disaster planning, some of which were developed for Afghanistan, if you're interested in any of those. Or if you're asked to present on that topic, I'd be very glad to have you steal any of my lectures, and you can use them for your presentation.
Thank you, Jim. So let's go. Can we shift to Gavin then, Chulabong? So, Gavin, are you online with us there?
Yes, I am, Gene.
Great. Gavin is in Bethesda right now, but as I said before, he often travels around the world, and he's a master of being able to be an instructor under that situation as well. Students are always very, very complimentary of him and his responsiveness. And they're also very complimentary of all of his experience. So, Gavin, take it away and tell us a bit about your experience in hospital preparedness.
Thanks, Gene. Hi, everyone. I just want to emphasise that for everyone in the room, please follow up with Jim and take his very, very kind offer. If you put together all that valuable information that Jim brings to the table, it would cost you thousands and thousands of dollars just to purchase it. So please follow up with Jim. He's got so much experience and it really is valuable. So I teach 3 courses in public health preparedness at Penn State: PHP 510. PHP 831 and PHP 832. I've recently just come back from Papua New Guinea on a trip where often we think of emergencies and disasters as fast moving, as something that happens that requires a rapid response. I was deployed to a place called Daru Island, that you can see at the top of this map, and Daru Island is experiencing now a very slow moving multi-drug resistant TB and extensively drug-resistant TB outbreak. Daru Island has about a population of approximately 10,000 people, and while I was there, we found or accounted for 284 multi-drug resistant TB patients that were laboratory confirmed, and while I was in the hospital, there was 12 extensively drug-resistant TB patients. And the challenge we have, yes, we can send physicians and nurses to these locations, to the general hospital where these patients are, but also this is about complexity. This is about addressing systems of systems. So one of the job that myself and my team had was conducting risk assessments, needs assessments, and looking at how the systems were working and where the gaps and the needs were. In 2014, I had 3 deployments to West Africa. I went to Nigeria, Liberia, and Sierra Leone. And I think this picture here from Jerome Delay really captures some of the challenges that we faced. The little girl in the photo, the symptoms that she has is fever. She hasn't been laboratory diagnosed yet. She just has fever. And the challenge there is that we are leading her away into the ambulance, and because she had fever at that particular time in West Africa, she's going straight to the Ebola hospital. What you don't see in the photo is the hundreds and hundreds of people, the family, the friends, the relatives, the community, standing to the right of this photo, crying, screaming, "Don't take our child." And so not only did we respond to the need of the patients, but we also had to respond to the need of the community. Right now, I'm the Global Health Security Advisor for a company called Apt Associates. I participate in meetings in London, I participate in meetings in Geneva, and also participate on Global Health Security roundtables here in Washington, D.C., which is really led by the National Security Council. One of the big areas that we're focusing on at the moment is that within the global health security agenda and the international health regulations, states that every country must have a public health emergency operations centre functioning according to standards, training, biosurveillance, and being able to activate that emergency response within 120 minutes of the identification of a public health emergency. We know that out of 196 countries, over 80% of those countries can't currently do that. And so I spend a lot of my time working and travelling overseas, working in countries, standing up emergency operations centres, but then taking a all of hazards, whole community approach to make them functional. One of the lessons learned from Ebola was that every person that got deployed carried a cell phone, and that became the main tool that we used. And within that, using the cell phone as your main tool, you're looking at how to use text messages, how to take photos, how to take video, how to record voice, how to increase your situational awareness. So in this map here, you can see the coverage of cell phones, the cell phone coverage, which is the red circles. The blue dots are the health facilities, the hospitals and the clinics that actually had cell service. And then the triangles where Ebola patients were going on a daily basis, but they didn't have coverage. And that was one of our big challenges. On the right-hand side are all the programs that we used within the hospitals to record data. And it's really important within our training that we focus on how to send a text message with the appropriate data, and then how to feed into these many different platforms that we use on a regular basis to collect the data. So what happens when you're in the field and you're collecting patient data, you're collecting community data, and you're doing risk assessments? Well, it goes into something like this, and this is a dashboard. This is a typical dashboard that we use in public health. One to show on the left-hand side, these were the critical mission functions that are listed. At the top are the countries that we were working in, and it uses a traffic light system: red, green, yellow. And of course, red means that we need to do more work, yellow means that we're doing some work, and green means that we are functional. But within also those squares is a percentage, and it gives us, and it allows us to drill down to a dashboard approach that works on your computer, your laptop, your tablet, or your cell phone to find out where the information is coming from and what are the needs and the responses that we have to make. We also do a lot of facility risk assessments. And one of the courses I teach at Penn State is all about how to design, facilitate exercises, and to conduct risk assessments. And this is a typical dashboard approach for a hospital where we're looking at how is that hospital doing in its preparedness and what other work needs to be done, and to give that to an executive board or a hospital director or other really important decision makers within the hospital. We have to visualize that data. And this is a typical dashboard of visualizing that data. I want to tell you a story about my first deployment to Nigeria, and this photo is a colleague of mine, Tim Trevan. These are the nurses that we first trained in Nigeria. We're going back now to August 2014. So Tim and I and a much larger team spent time in Nigeria setting up Ebola hospitals, Ebola treatment rooms, but also training healthcare staff to deal with highly infectious disease patients. It was August 24th, 2014 at 10 o'clock in the morning, where we were conducting our training, and we received a phone call at 1 p.m. in the afternoon: your first Ebola patient is going to arrive. So what do? Well, training stops, we all take a break, and we get ready for the arrival of our first Ebola patient. That first Ebola patient arrived at 1 p.m. All the staff that we trained successfully took the Ebola patient out of this ambulance here into the Ebola hospital. We got everything set up. Everyone was in their personal protective equipment. All their resources and equipment were ready, and they started treating that patient. I came back out to talk to Dr. Parker from the Ministry of Health and said, who is going to decontaminate the ambulance? And he picked up a piece of paper and he looked at his checklist and said, it's not on my checklist. And I said, well, that ambulance can't leave until we decontaminate. So again, I had to put on my personal protective equipment, sit down with the team and start teaching them and showing them how to decontaminate an ambulance, which took us nearly 4 hours to do. A lot of the messaging that we train and teach and prepare for is how to, well, get messages across to our own healthcare community, but also the public at large. And again, what we saw that a lot of the advice that was provided for Ebola wasn't always provided on sound facts and good science. And so we saw a lot of messages like this put out that said, stop Ebola. Now, if I said to you today, stop Ebola, I haven't given you any behavioral action. I haven't told you what to do. I haven't helped you in any way. And we found a lot of that messaging just wasn't working. We saw the same for Zika last year, where even down in Florida and Puerto Rico, a lot of the government programs were saying, stop Zika. It means absolutely nothing and doesn't provide the necessary behavioral actions or even the functional elements or the operation or the things you need to do to decrease the risk. So the night that we got our first Ebola patient, I went on national TV in Nigeria. This is the national news at 7:30 p.m. And I thought I was fully prepared. I got all the questions about what are we doing with the Ebola patient? How are we doing? Do we expect more? And then this reporter, she caught me by surprise. And she'd been doing her homework, and she was searching Facebook, and she found that a university student in Nigeria had sent out messages that if you made a very high concentrated salt solution and you drank that solution, it would protect you from Ebola. Completely false, completely wrong. Well, that message by that student on Facebook led to 4 deaths, and the student was subsequently went to trial and was found guilty and was sent to prison. So it's really important that as part of our training, we understand that people do use social media. We understand that not everything that's put on social media is true, and then we need to do our ground truthing and fact verification. But it was a really important point here that this journalist had seen this, and that was one of the questions that she asked me during that interview. After that interview, I went back to the hotel, had some dinner, then went back to the hospital that night. We had our first Ebola patient in the hospital. Later that night, we were attacked by 3,000 people from the local community. And it's really important that because in the absence of advice, we found that our community would react. And what happened here, all the time that we'd spent setting up the hospital to treat Ebola patients, all the time that we spent training the physicians, the doctors, the nurses, and all the other staff that were required to look after the Ebola hospital, the government and even ourselves hadn't appropriately or properly engaged with the community. And therefore, that night, the community were angry that we'd put an Ebola patient in their hospital, and we were attacked. And it's really important to note that the 3,000 people that attacked the hospital, they didn't break any equipment, they didn't hurt any of us, but they spray painted the whole hospital saying, "Oh, no more Ebola." But again, what you won't find in your training, when you're being attacked by 3,000 people and you're really scared, you don't know what the outcome's going to be, you don't know what the threat is, you don't know what they're going to do if they find you, you as a leader, you as a decision maker have to protect the team. So the decision I made that night was everyone put on your personal protective equipment, and the safest place in that hospital was for all of us to huddle in the room where the Ebola patient was. So we all went in with the Ebola patient, huddled against the corner, very scared, but all of us were untouched. We didn't get hurt by the community. The next day we engaged with the community, with the government, and it was decided that 2 of the community members would be put on the hospital executive board, and they would participate in every meeting that we conducted so that we were open and transparent. So big lesson learned there. When you get into many disasters, we're foreigners, we're not from the local area, but you do need to engage that community. We often deal and teach and we train to deal with complexities and a cascade of events. But whenever there's a disaster, something else is going to happen. And it was really interesting with the work that we were doing in US hospitals that we weren't waiting for the CDC to release specific guidelines on what to do. But the media had picked up that they believed that US hospitals were waiting for new CDC Ebola guidelines. And in this photo here is Seema Yasmin from the Dallas Star. She's also a physician, an epidemiologist, but also a journalist. Wolf Blitzer and myself talking about the US hospital healthcare system has already started with preparedness. We've started with training. We're starting to develop the skills and the needs and the functions that we need to put into place if we do get a highly infectious disease patient like Ebola. What was interesting about these CDC guidelines, when they came out, they were 30 pages long. And it took so much effort and time for people within the hospital, for the nurses and the physicians to read this and to be able to apply them. So it was a very complex and very complicated situation. We also focus at Penn State on our training on how to talk both to colleagues, to other members of our profession, but also how to talk to the community. And one of the challenges we had here in this interview was that a doctor had died from Ebola, but his laboratory test, the real-time PCR the state of the diagnostic testing that we had, didn't show that he was negative, didn't show that he was positive, didn't show that he had a viremia, didn't show that he had Ebola. And that sometimes happens with laboratory testing. So we as the healthcare physicians and nurses and first responders have to be prepared for that, because when we're asked that question, we have to be able to tell the public why sometimes the tests do work and why there might be sometimes errors. And so everything we do is based on communication, crisis decision leadership and decision making. And it's really important that within the training and the courses that we give you at Penn State, we'll help you develop appropriate messages that convey information from a medical healthcare perspective that are very easy to understand and interpret. So with the last slide, I want to leave you with where we are now. And one of the big things in global health security, the Global Health Security Agenda was launched in 2014 as an accelerator model for the international health regulations to help countries, hospitals, healthcare clinics, and governments get prepared for emergencies and disasters. We are seeing over 55 countries now have done joint external evaluations and assessments and have developed 5-year roadmaps. One of the key areas that we're focusing on now is what we're seeing, this transition for public health emergency operation centres to have broader mandates, new institutional models, really focus on all hazards and whole community approaches, because I just came back last week from a meeting in Boston with the US military, with FEMA and HHS and CDC, where we talked about that within public health, many of us sit there and we do the planning and preparedness, but when the actual event happens, the military turn up, the corporate sector, the private sector, academia turns up, but they've never been really part of the planning and preparedness processes and meetings that we've conducted before the event. So this is a real paradigm shift now in moving to create an all-hazards approach with the whole community. So thanks, Gene.
Yeah, now I'm back. Okay, good. The microphone's ready here. So, Jim, did you want to follow up on your earlier comment about the change in Ebola, understanding the epidemiology of Ebola? Any more about that? No? Good. Okay, good. Well, let's go on then to have Bruce Rudy speak here. Bruce is, as I said before, he's here with the emergency medicine as well as a coroner with Lebanon County, our neighboring county. So, here you go.
Thank you. Good afternoon. I was happy to see all the attendance we had here, and then I saw there was food in the back, so then I realized us panelists had nothing to do with the turnout that we got this afternoon. As he said, I'm a physician assistant here in the emergency department, and he promoted me to coroner. I'm only the chief deputy. I haven't run for election yet, so I'm only the chief deputy with the Lebanon County Coroner's Office, but I've been doing that for 20 years. And I'm also the public information officer for Western Lebanon Emergency Management Agency. So I'm going to try to give a little bit of an ante-mortem perspective and post-mortem perspective I'm going to be talking a little bit about influenza. As we know, that was a big thing back in about 2009, 2010, when everyone acted like the world was going to come to an end. So what's anything without definitions? Influenza, obviously, as the medical people in here know, and I thought that we were going to be talking to Croatian medical students, so I'm going to probably have to switch gears a little bit in here. I don't want to be insulting, but we always do definitions. Obviously, we know it's a highly infectious viral upper respiratory illness that normally affects the nose, throat, and the lungs. Hallmark signs of this are usually going to be headache, fever, fatigue, sore throat, cough. Just from a clinical perspective, I think probably the two most hallmark signs are going to be extreme fatigue and fever. About 50% of the people will have a fever greater than 102.2, and fatigue is usually like a very debilitating thing. Like someone who starts experiencing symptoms about 9 o'clock in the morning generally is going to be home in bed by noon. It's that debilitating. This is different than what we call a man cold, where people show up to the ER all the time thinking they're dying, and they have, they sneezed twice and blew their nose twice, and they think they're on their way to the morgue. So the true influenza is a very debilitating illness, has a very high mortality rate in those who are chronically ill and the elderly. So we talk, and I hope this is a discussion. This isn't just going to be a lecture with me talking at people. This is going to have huge social impacts on our society. This is going to need significant pre-planning with employees. Here for the medical center, we obviously know we have to have surge plans in place. How well the surge plans are really in place is we haven't found out yet. Obviously, we know things like school closings are going to affect us. This is no longer a father knows best type society where we have a dad that works, mom stays at home and takes care of the kids. We have single parents. We're going to have multiple single parents here who are going to have kids at home who are going to need care and are not going to be able to show up from work. There's going to be homebound people, elderly, who are going to need constant care. We pretty much have estimated that 30% of the population, if we were to get a true influenza epidemic, 30% of society is going to be affected by this and incapacitated. The one thing we tend to forget to do is to include ourselves in that 30%. So we set up a scenario one time for the incident command when we were doing a roundtable, and we stuck a little index card in 30% of the folders and said to the people, okay, you're now affected, you're excused from the table, who's going to replace you? And of course, everybody sat there with their mouths wide open because they hadn't thought about themselves being affected by this. So when all these things that we're talking about, we have to include ourselves. So that means 30% of our physicians here at the Med Center are going to be affected, 30% of the nurses, 30% of mortuary services are going to be affected. So we have to take into account what we're going to do when that happens. As we talked about, it was about 2009, 2010 when we had the H1N1. They did do studies, kept track from 1958 to 1968 over the H1N1 flu. There was an estimated 90 million people infected over that amount of time, 2 billion worldwide. If this were to happen again, we would anticipate about 9.9 million hospitalizations. There would be 1.4 million ICU admissions and about 1.9 million deaths. So we talked about, we just said 1.9 million deaths. How many funeral homes are in the United States? Anybody know? No former funeral directors in the medical school class? According to 2010, the National Funeral Directors Association, there's 20,000 funeral homes. So if we have 1.9 million deaths in 20,000 funeral homes, that comes out to about what, 95 deaths per funeral home. How many funeral homes do you think are prepared to handle 95 deaths in what, a few weeks' time? Maybe a month's time? And now we throw in the factor that 30% of those funeral homes are now incapacitated, because we have to include those into being incapacitated. So now we're looking at every funeral home up to about 120 deaths that they have to manage. We talked again about the current numbers, about we have 1 million hospital beds, and we're expected 9.9 million hospitalizations. Anyone have thoughts what we're going to do here at Hershey? Anybody have an idea what the plan was? Someone has to stand at the door and wave goodbye. They literally had planned, we're going to be telling people in Lebanon County, they're telling people you're going to have to go home and basically die. Literally, that was the plan, because there's just no beds, no way to deal with it all. Who's going to enforce that? Anybody know? Plan was going to have to activate the National Guard, provide security at the hospitals, and turn people away. Can you imagine that in Hershey? We have a bunch of residents here. With the population we have showing up who think they're entitled, how well do you think that's going to go over? Most of you can't see the looks on their faces, but their looks on their faces was that's not going to go over well. As I was going to be talking, I won't go over this because you guys know this information since you go here. So what are we going to do? Someone's going to have to prioritize who's going to be coming in and who isn't, who's going to be turned down. We're going to have to start looking at who's going to be eligible to be admitted, who's going to be getting antiviral drugs. Obviously, we have to take care of ourselves, because if we're the ones who are on the front line and we get ill, we're not going to be able to take care of people. We're going to have the high-risk outpatients, your chronic diabetics, heart failure patients, other healthcare workers who are going to be out dealing with the public, the responders, EMS, nursing home workers, obviously healthcare workers in special units. Again, we talked about the high-risk patients, those are chronically ill, diabetes. We're also going to have to get the private community involved in this. We're going to have to develop preparedness plans. We talked about there's going to be a lot of deaths. Anyone we can think of in the private sector whose help we're going to need. Obviously, funeral directors are in the private sector. Who else are we going to need? Any thoughts? How about people with backhoes? We need someone to dig up the ground to bury them, don't we? I mean, it's not like something we can just dump them off in the cemetery and hope that the caskets migrate down into the ground. We're going to need things like, also, coffins don't just go in the ground, they go into a vault in the ground. We're going to need manufacturers who are going to be producing these things. I doubt we have 1.9 million vaults lying around somewhere. So here at the medical center, we're going to have a huge number of deaths. Anybody know how many bodies our morgue can store? As of this morning, 13. What are we going to do with them? I know what I'm going to be doing. Making a phone call to Giant Grocery Store. They have refrigerator trucks, don't they? Now, what's the problem with that? Now, we're lucky here at Hershey. We have an underground garage, right? So the public most likely is not going to see that. So if we're in Lebanon, where they don't have an underground garage, and we have a reefer truck out there that says Giant or Weiss or Turkey Hill, and there's 50 dead bodies in it, what might that do to their business in the future when next time you go to the grocery store to buy food? And all you see is, remember, there were 50 dead avian flu bodies in that truck. So now we have to, so obviously we need the reefer trucks, but we need to cover those up. So now we have to have plans ahead of time to cover those things with tarps so that the public isn't seeing this. And we all know everybody's got one of these things now to film it, and it goes viral in no time. So this is a public relations disaster, and how you deal with this. As we said, we need the funeral homes involvement, but these are also private businesses. We can't mandate they come and get them when we want. So we have to have cooperation from them. As I said, here at Hershey, we're a little bit lucky because we could have the reefer trucks underground and we don't see how the bodies are being moved. Picture again with a cell phone, if it was out in the public somewhere, not all funeral directors are smooth around the edges. They might show up in their pickup truck for the body. If someone sees two funeral directors slinging a body bag up into the back of the pickup truck, and that would go viral, that would be a public relations disaster. So this is something that has to be worked out with funeral directors also, that this is a huge public event. Everything has to be done, looked in a respectful manner. Generally, when there's a huge public event, it's strongly recommended that the funeral directors arrive in coat and ties, they arrive in a hearse, and that they have a coffin in the back of the hearse that looks respectful to the family. Some of you probably aren't here old enough to remember when Reagan died in 95, 96? When did he die? No, 2006, wasn't it? Remember when they took his body out of the house? It was in a coffin. It wasn't in a body bag that like we see in Chicago and New York at homicide scenes, where two guys are just lugging a limp body bag. Things that we can do to help try to prevent this, obviously, as we're talking about planning, we know the standard practicing health, good habits, washing your hands, all that type of thing. If it really does break out, what are things in your department that we can do to try to prevent it? Come on, all you emergency medicine residents, you've had this stuff. We already talked about hand washing. Generally, if it's the avian flu, we should just be able to wear the standard mask, gowns, gloves, correct? But if it turns out to be something non-avian flu, we might need the HEPA masks, correct? Do we have them? Everyone's smiling. We don't know. Does anyone know where they are? Anybody trained to use them? I haven't. I don't even know where they are. I don't even know if we have them, to be honest with you. So this is something, obviously, that we still need to be training and to do. So we talked about a little bit here already about having this needed equipment, having things planned out with local emergencies, public health, planning the exercises. That's a crucial thing in the planning, and it always sounds good, right? How many people have here participated in disaster planning? A few. What are the complications of it? It's always in the workday, right? Can you imagine if we say to the head of the hospital, now we want to plan, we want to shut down the ORs for an entire day while we do this disaster drill because we're going to need to use the ORs. How much money would the hospital lose? Millions? Think you're going to get an administrator to go along with that? What's our reaction every time the fire alarm even rings? Does anybody even pay attention anymore? We just keep, the ambulances just keep bringing people in with the fire alarms ringing, don't they? So our disaster drills really don't always turn out to be quite as effective as what we want them to be. But yet, it's still, even tabletop is still better than nothing, so that planning for these things really does make a difference. Most times when there has been a disaster, the pre-planning has really paid off. Even they did a post-disaster assessment out in Minneapolis when they had the bridge collapse out there. And because of their pre-planning, all the incident commanders had done so much, they all knew each other on a first name basis. Everybody knew everybody, had the plan, everything well planned out, and everybody was cooperative and they got the job done. Unlike some other places, like even the World Trade Center where it was known as organized chaos. One department wasn't speaking to another. Nobody knew what the other group was doing. Obviously, we talked a little bit about this also, the personal protection equipment. And anybody have any questions or other comments?
So it's a good time to shift over to you all. We've got a few more minutes before 1 o'clock. So any questions or comments? Keep our panel members here. And we still have Gavin, looks like he's still alive. So we got to respond as well. Microphone. His microphone.
So any questions or comments from folks? Yes.
You painted a dire picture. Is your job like in Lebanon? Do something about that? I mean, is this something that you anticipate happening? Is this something that happens easily, or is this?
Yeah, it happens easily. My night. Yeah, he was asking if this is something that we prepare for. I think your question is if we prepare for in Lebanon, or as part of my job to prepare for it. I don't have legal authority to prepare for it. I do go to events, and I prepare in my own mind anyways what I'm going to do. My nightmare is that one of the planes on descent to Philadelphia is going to crash over Lebanon, and suddenly I have 150 dead bodies that I have to account for. And when that happens, it is the local coroner's jurisdiction and is his or her responsibility to positively identify each body. There are DMORT teams that are available. It sounds good, but they charge the county, I think it's $10,000 per day, and the county is responsible to pay the federal government for that. So it still does fall to the local county's jurisdiction for those type of things.
So I guess I just want to, picking up on what Bruce said there, so I think that I would, if you're very interested in public health hospital preparedness, you really need to get involved in sort of the community emergency response teams, the CERT teams, and the training activities that they are engaged in. Actually, here in South Central Pennsylvania, we do have a fairly active group that spans the hospitals and spans a number of counties that do trainings. And I guess just picking back up on our program here, so we do work closely with our Pennsylvania Commonwealth colleagues, both in emergency management, in public health, in human services, in the law enforcement area as well. So I guess I'm proud of our program because we bring all of those perspectives into this planning, into the operations, into the exercises that are done. But that's really an incredibly important part of a local response to the situations. Other questions or comments, Bruce?
Getting back to like a disaster I was talking about of a plane crash, and some of the things that have to go into trying to recover the bodies. The average like major plane crash has about 10,000 on average 10,000 body parts scattered. And the job is to all they do is try to identify every body, and once they have enough portion of a body, they stop putting it's not like they try to put the entire body back together as much as they can. Like if all they had was my hand and there was a ring on it, it has Bruce Rudy ring on it, they would use that, and if I had a fingerprint, they would not try to find my head, legs, torso, or anything else to line up with it, and then they just put all those other body parts into a big pile. They'll give the family the option to say, well, if you're whatever, weigh 200 pounds, we'll give you that hand and 195 pounds of flesh to bury if you want. If you don't care, it just goes into like a mass burial or cremation, the remainder of the body parts. So if a body's intact, the family will get that whole body. If it's a head, a torso, or a hand, that's all the family really gets, unless they want an equal pound of body flesh. And it's a huge deal trying to decide what we're going to salvage or not. Like I said, so you have a blade of grass that has a drop of blood on it. Are you going to try to use that to try to identify somebody, or if it's got, some hunk of fat on it? Someone has to make a decision what we're going to throw out and what we're going to try to salvage for family. It's a very stressful thing on the workers. They generally will work and make maybe 4-hour shifts, and then they need to get away with it because it's so stressful and a depressing thing. Most of them find they have a hard time getting back to their regular job when what they've dealt with and what they've seen families going with, and then you come back here to an ER to see people complaining because they had to wait 30 minutes when they had the sniffles. And they say they really have a hard time adjusting to sometimes the Americans' expectations after an event like that.
One additional local resource we have that we can tap is Fort Indiantown Gap, which is a big National Guard training center. And they've got a whole bunch of heavy lift helicopters. And for example, we folded them into the plans that I developed when I was staffing the home Penn State football games. We had to plan for if there was a stadium collapse, how are we going to get 5,000 casualties out of State College? And the method we came up with was to mobilize the National Guard heavy lift choppers from Fort Indiantown Gap. And they also have a number of other kinds of personnel, such as mortuary teams that can also be mobilized.
Other comments or questions? So we have just a minute or two left here. So I guess I would, particularly as you were talking, Bruce, I thought of the question about, for our panelists here, about have they been in situations where priorities have had to be made, where triage situations were important, and if you could talk a little bit about how you've gone about doing, how you've either personally been involved with those or how you've had to advise other people on that situation.
Well, actually, I've published on this, and if you look at the entire history of the Western world and Israel, there's only been one disaster since World War II where triage had to be done and some patients pronounced expectant. Do you know what that event was? Only one event, all the Western world. It's Katrina. That's it. And so under almost all foreseeable disaster circumstances that we are going to have to deal with, we should be able to provide maximum care to the patients up front if they're properly field triaged. And that was the situation, for instance, at the World Trade Center, where all the seriously injured casualties were given maximum emergent surgical care. So the odds of us being in a situation where we're going to have to use military-style triage are extremely low. Now, of course, we face those situations in Afghanistan and occasionally in Iraq. But most of the experience of our military in Iraq was that everybody there that's injured can be given maximum care right from the beginning.
Gavin, anything to add?
Yes, Gene, I think what's important from the program that we run, the faculty that we work with, we really strive to go the extra mile with our students. So not only do you get the chance to participate in the courses, but we also ensure that we want to get you that real world experience if possible, but we also want you to have contact with people you can work with, or maybe where you live in the community, that are involved in emergency management, public health preparedness. And in the course that I'm teaching now this week, all the students had to go out and actually call hospitals or call the emergency management local agency to get look at plans and make an assessment of plans, but it increases their network. So as a faculty, we really try to increase the network of the students who attend the courses and get them real world experience. And I think that's really important to state.
Picking up on that then as well. So we do offer an individual studies course. So we've had a number of students who have come through who have designed their own course based upon their interest. This past summer I worked with students in Washington State, and they were planning a response for a small four-year university there. It's interesting, that's the third university planning situation that I've been in as an independent study advisor. We have Melissa Linsky, Dr. Linsky. She's a surgical resident here. She's just finished our program, and she's conducting a survey of surgical residency programs around the U.S. and their preparation for mass casualty events of the residents. So as Gavin said, we do try to encourage people to apply to get involved locally or with their own profession in the program as well. We are approaching 1 o'clock, so let me say thank you to Chulapal for keeping us coordinated. Thank you, Gavin. And Jim and Bruce, thank you for joining us here. Everybody had a good day. I'm going to run these in the back, and you're welcome to pick up one and take it on out.